It's a huge thrill for me to be able to welcome you to this two-part high-level webinar on child and adolescent mental health being hosted by the Institute of Global Health Equity Research at the University of Global Health Equity. As I said, my name's Professor Timothy Carey. I'm the inaugural director of the Institute of Global Health Equity Research and the Andrew Weiss Chair of Research in Global Health. Today we have a two-part event, the launch of the Rwandan Program and its method to screen the risk of depression among school children. And we have an amazing lineup of people who will be speaking to that topic. And then following that, we have an international panel of experts discussing the impact of the COVID-19 crisis on the mental health of children and adolescents. And while COVID-19 has been absolutely awful in lots of ways globally, it has allowed us to assemble stellar lineups of international and national experts like we have today. So I'm just going to take a few minutes to run through the bios of the people we have today so that you can get some sense of just the depth and breadth of expertise that we're incredibly fortunate to have assembled here today. Our first speaker is the Honourable Minister, Dr. Tharcisse Mpunga, who has over 15 years of experience in leadership in the Rwandan healthcare sector. As Director General of Butaro Hospital, he led the development and implementation of the Butaro Centre of Excellence in Cancer Care until his appointment as Rwanda's Minister of State in charge of primary healthcare in 2020. Research is critical to guiding evidence-based cancer policy and programs in Rwanda, and he has been heavily engaged in research, including collaborating with Dana-Farber Cancer Institute physicians on a cluster randomized controlled trial of breast cancer early diagnosis in the Burera district. He's now pursuing a doctorate degree in cancer epidemiology and studying infections associated with cancer in Rwanda. The Honourable Dr. Tharcisse has published manuscripts about surgical oncologic care, the development of pathology capacity, and has led several projects assessing the use of telepathology services and building capacity for immunohistochemistry. He's invested in facilitating effective and feasible strategies for early detection of women's cancers. Welcome, Dr. Tharcisse. It's a thrill to have you here as the Honourable Minister for the Government of Rwanda. We also have with us today, it's a pleasure for me to be able to welcome and introduce to you Dr. Florence Bengana, who's a psychiatrist and public health specialist and the WHO Regional Advisor for Mental Health and Substance Abuse. Dr. Bengana has been working with the WHO on and off, beginning in 2014 in Liberia during the Ebola epidemic, and then to Sierra Leone for post-Ebola strengthening of the mental health services, before heading northeast to Nigeria to support the response to the Boko Haram insurgency. From 2007 to 2014, Dr. Bengana was a research fellow with Makerere University School of Public Health and was PI for Mental Health Beyond Facilities, a GCC-funded project based at Makerere University School of Public Health from 2012 to 2014, which was implemented in Uganda, Liberia, and Nepal. Her goal is to strengthen mental health policy, planning and financing in sub-Saharan Africa and other low and middle income countries. Dr. Bengana worked as the National Mental Health Coordinator in Uganda from 1996 to 2000, where she was able to get mental health integrated into the health policy. From 2000 to 2006, she worked at the World Bank in Washington, DC, doing analytic activities, knowledge management, operations, and partnership activities. She has an interest in the area of gender and health and has consulted for Population Council, UNFPA, ECA, and the AU. It's wonderful to have you here today, Dr. Bengana. Thanks so much for your time. It's also a privilege for me and an honour to be able to introduce to you and welcome Dr. John Nkengasong, the Director of the Africa CDC. Prior to his current position, he served as the Acting Deputy Principal Director of the Centre for Global Health at the United States Centers for Disease Control and Prevention, the US CDC, and Chief of the International Laboratory Branch at the Division of Global HIV and TB at the US CDC. He received a Master's in Tropical Biomedical Science at the Institute of Tropical Medicine in Antwerp, Belgium, and a doctorate in Medical Sciences in Virology from the University of Brussels in Belgium. He's received numerous awards for his work, including the Shepard Award and the William Watson Medal of Excellence, which is the highest recognition awarded by the CDC. He's also recipient of the Knight of Honour Medal by the government of Côte d'Ivoire, was knighted in 2017 as the Officer of Lion by the President of Senegal, H.E. Macky Sall, and knighted in November 2018 by the government of Cameroon for his significant contributions to public health. He is an adjunct professor at the Emory School of Public Health, Emory University in Atlanta, Georgia, and serves on several international advisory boards, including the Coalition for Epidemic Preparedness Initiative and the International AIDS Vaccine Initiative, among others. He's authored over 250 peer-reviewed articles in international journals and published several book chapters. Thanks so much for your time today, Dr. John. And now I'd love to introduce to you and welcome Professor Agnes Vinoguajo, who has a medical degree, a master's in pediatrics, and a PhD, and she's the Vice Chancellor of the University of Global Health Equity in Rwanda. She previously worked as the Executive Secretary of Rwanda's National AIDS Control Commission and as Permanent Secretary of the Ministry of Health before becoming the Minister of Health for the Government of Rwanda. She serves as a Senior Advisor to the Director General of the WHO, as Senior Lecturer at Harvard Medical School, and also Adjunct Clinical Professor at Dartmouth. She is a member of the US National Academy of Medicine and a Fellow of the African Academy of Sciences. She's published over 190 peer-reviewed articles and was named among the 100 most influential African women for 2020. I learn something new from Professor Vinoguajo every time we have a conversation, so I'm really looking forward to hearing her again today. We're also going to hear from Dr. Sabin Nsanzimana, the Director General of the Rwanda Biomedical Center. Dr. Nsanzimana holds a medical degree and a master's degree in clinical epidemiology from the National University of Rwanda, as well as a PhD in epidemiology from the Swiss Tropical and Public Health Institute at the University of Basel in Switzerland. He serves as a fellow at the African Scientific Institute, as well as a fellow of the Royal College of Physicians of Edinburgh, and is assistant professor of global health at the University of Global Health Equity, as well as teaching epidemiology and research methodology at the University of Rwanda. He has been working for the health sector for over 14 years with extensive experience in the control of infectious diseases and research with more than 120 published scientific articles. It's so great to have you here, Dr. Nsanzimana. And Dr. Darius Gashoma. Nope, wrong slide. Sorry about that. Oh, yes. Sorry, okay, we'll go to Mr. Eric Romera. It's awesome to have you here, Mr. Romera. Mr. Romera is a trained biostatistician with a Master of Science degree in clinical epidemiology from the University of Rwanda School of Public Health, and is a PhD candidate in epidemiology at the Swiss Tropical and Public Health Institute at the University of Basel in Switzerland. He currently serves as the Director of HIV Surveillance and Research for the Institute of HIV Disease Prevention and Control at the Rwanda Biomedical Center. Mr. Rwanda has more than 11 years of experience in the programmatic design of delivery of prevention, care, treatment, and support service delivery for HIV monitoring and evaluation, health system and observational and clinical research. As a researcher, he has extensive experience leading the development and implementation of study protocols, conducting data analyses, and the scientific communication of study findings. He has co-authored more than 20 peer-reviewed scientific publications and has presented research findings at national and international scientific conferences. Great to have you here, Mr. Romero. And now over to Dr. Darius Gashoma, who's a practicing clinical psychologist working as senior lecturer in the mental health department, College of Medicine and Health Sciences at the University of Rwanda. Dr. Gashoma provides psychological services to adolescents and adults at the mental health department at the Kigali University Teaching Hospital. He has a track record of research and associated publications in the field of mental health in Rwanda. His primary areas of research and publication are in the treatment, development, and evaluation of interventions related to post-traumatic stress disorder, depression and substance abuse, global mental health, maternal and child health, and community-based programs. Dr. Gashoma also serves as the chairperson of the Board of Commissioners of the National Commission for Children in Rwanda. So that's the lineup of the people we have to speak today. And to begin, I'd like to welcome Dr. Bengana to lead our presentation.
Will I be able to share my screen?
I think we've already got your slides, Dr. Bengana.
Okay, because I'm going to be moving very fast. So
Okay.
I hope you'll be able to keep up. Yes. Right. So thank you so much for inviting me to be a part of this esteemed group of people. I'm going to be talking very quickly, giving an overview of depression in school-going children, global and regional perspectives. Can we have the next slide, please? So this slide shows the global burden of mental and neurological disorders from 2016. As you can see, other developing countries, which would include all the countries or almost all the countries in sub-Saharan Africa, depressive disorders are one of the biggest burden areas for this region, as well as for the rest of the world. The other area of concern, of course, is epilepsy, but we shall not go into that today. Most of the data that we have on the continent is from South Africa, so I present a little bit of the data here. Next slide, I hope you're on that slide as well. I have just 3 slides as examples from South Africa. We have rates of depression of about 26% in that first study on the left, depressive symptoms. The one below that, the rates are 24.7% depressive disorder and 31.5% 1-year prevalence of depression, as well as 20.8% of anxiety. This is all among, the lower one is university students and the other one is for students. And then on the right-hand side, we have adolescents growing up in post-apartheid South Africa. And we have 41% depression, 16% anxiety, and 21% PTSD. So there are very high rates of depression among that population. There are also a few studies out of Uganda and Ethiopia, which show rates of about 7.6%. On average, that seems to be quite the rate. And then Ethiopia, among orphans, they found 36.4%. So the etiology is severe physical punishment, war and trauma, chronic poverty, orphanhood, HIV and AIDS, as well as child abuse. And we are concerned about depression in childhood because persistent depressive disorder, when it is not treated, is linked to decreased earnings, 15 years, even longer after that. So in adulthood, they would have decreased earnings, which should be a concern for us. I will talk just a little bit about suicide in the world. As you can see here, those are the rates of suicide. And you can see that it starts off at about 10 years, 15 years, 20 years, we have very high rates. And the red bar, are you on the next slide? I keep pushing mine and thinking you're with me. So the red bar is the low and middle income countries. You can see what the burden of suicide is among our populations. Unfortunately, it is very, very silent because we actually don't hear a lot about the suicide, only until recently. The next slide again shows the same numbers, and I will not dwell on this one too much, but it just emphasizes the number of suicides increasing as we go up in the age up to 25 to 29 years. So against this background, the next slide, please, which has government mental health expenditure. Against this background, we have a very low investment in mental health in our countries, about 10 cents per capita in the Africa region, which is a big, big challenge. The next slide will show you where that investment is going. Part of it is mental health workforce. As you can see in Africa, we have less than one person per 100 population, but that less than one person is only one third of them are psychiatrists. The other one third are other paid mental health workers. So I had put in a timer, sorry about that. So what resources do we have? I will not dwell on this one too much, but WHO does have some resources to respond to the problem of depression, as well as other mental disorders among adolescents and young children. Thank you very much. Over to you.
Thank you so much, Dr. Bengani. Yes, it was a whirlwind tour, but high rates of suicide and depression and low spending globally is just a disastrous equation in anyone's book. So it was a fabulous presentation. We're now going to hear from the Honourable Minister, Dr. Tharcisse Mpunga, from the Minister of State at the Ministry of Health of Rwanda.
Thank you very much. It is my pleasure to be part of this important event to address the mental health needs of children affected by HIV in Rwanda. So when we intervene earlier in our life, we avoid problems that much and how challenging to address in adulthood. Children are particularly vulnerable. Therefore, we should invest more in mental health care and the psychological support. So it is estimated that 10% of world population, including 20% of children and adolescents, suffer from some sort of mental disorder. In Rwanda, mental health survey conducted in 2018 reported 10.2% prevalence of mental disorder among adolescents. So children affected by HIV not only suffer from the heavy burden of physical disease associated with chronic illness, but also they are at risk of developing mental health disorders. Depression is the most common complication in HIV-infected children and may occur during all phases of the infection with a wide range of negative impact to their life and for society in general. Previous studies have shown that HIV-infected children suffering from depression are more likely to develop maladaptive outcome and the behaviors, including school dropout, drug and alcohol abuse, and engagement in high-risk sexual behavior that increases the risk of HIV transmission. Depression also has a wide range of negative effects on the progression of illness in HIV-infected children. It decreases their immunity status and adherence to the antiretroviral therapy, which may result in potential development of drug resistance and decreased clinical effectiveness, increasing the disease cost burden and the mortality associated with illness. Therefore, it is imperative to explore the factors influencing the development of depression in HIV-infected children. Thankfully, we have saw progress improvement in our mental health policies in recent years by expanding the tools we have for confronting both serious mental illness in child and youth. So I am here now to celebrate the work done by the team led by Professor Agnes Vinoguajo, which developed a very useful tool for screening of depression among children affected by HIV, the Child Depression Screen Tool. So we congratulate the team for the work done to serve Rwandan children and the youth, in particular those who are affected by HIV and have mental health needs. Such a tool is needed because we have too many undiagnosed pediatric depression cases in our health facilities. So being free for charge and culturally adapted in Rwanda context, the tool will contribute to address financial burden and the clinical challenges caused by the existing tools normally developed in Western cultures. So the Ministry of Health and affiliated agencies, we are so proud of the tool, which brings a scientific evidence-based approach to easily detect depression experienced by children infected by HIV. I hope that this tool will contribute to promote greater mental health care, especially for children affected by HIV. I believe all of us here are convinced that it is very important to integrate it in our mental health practices as usual, and a simple tool to detect depression. So I thank you very much and congratulate the team.
Thank you, Honourable Dr. Tharcisse. It's a tremendous privilege to have you join us today to share your wisdom and insights around the complexity of depression in Rwanda and the development of this tool. I'm now going to welcome and thank Dr. Nsanzimana to speak.
Great. Good afternoon, good morning, everyone. Honourable Minister, distinguished panelists and friends, professors, and everyone who is connected to this interesting discussion. So I'll probably be brief because what the Minister mentioned is actually what we all have to allude to. And I'm sure we have more talks from the experts in this field. But I want to highlight a few things from my experience in HIV program in the decade and more, working with children and adults who are experiencing a number of issues with the disease, but also the consequences of the disease that are not spoken, that are not seen from the outside life of we all live in. So if we can maybe go through the slides, currently we are dealing with a pandemic and everyone knows that, but there are other silent pandemics that are not spoken, that are not mentioned. And I think depression is among these. Looking at the global statistics as presented here, you would see that this is just when it goes to children, it becomes even example. The 9% of the population aged 7 to 14, and in a study we did in 2016, we found that actually 25% of children aged this category of age were depressed, and they were on antiretroviral treatment, as I mentioned. It's another burden, it's another challenge. And adding on this depression is even huge for children who are facing these issues. The need for mental health care in Rwanda is even bigger given our history, given our past. That took lives, millions of lives. It is exacerbate the other challenges, other issues from the socioeconomic, from nutrition, that the government had to deal with from actually a health system that were almost inexistent, and then raising it and building all these programs, and now thinking of where we came from and the problem that persisted over 2 decades and more, that are now being translated from one generation to the other. And these are facts. So working on these mental health issues from the diagnosis, from the management side of it, it's not just, it's actually urgent. So when you look at the tools and the systems in place, you see already we have big rooms for improvements. We have a lack of appropriate screening tools in many ways, although a lot has been done, and personnel and people trained to handle all types of cases also is another area to improve moving forward. Maybe if we can move on to the next slides, and I will not be long. This is probably my last slide if I hand over to others. So now the thing is, what do we need to do from what we've done, from what we have, and what we need to do moving forward? We need to design a tool that is important and useful and adapted to these groups of people in schools, those who are not in school yet, for teachers who will be managing these children, and for parents. And this tool is needed not only for the children, but also for the people around them. So this will not happen if we don't have a strong routine surveillance of these issues of depression, especially for children with chronic diseases. So looking at it in a holistic way, not just in isolation or for specific people, as the minister mentioned, we don't need to borrow tools from another part of the world. We need to have things adapted to where we live, because that is how we can solve the problems adaptively. So briefly, this is what I think from the perspective of the Rwanda Biomedical Center as an implementing agency under the Ministry of Health in Rwanda, from the past and the current. I'll probably not mention what others will mention. This is the challenge, and I look forward to see the solutions that is being hope be presented by excellent speakers who will come after me. Thank you so much.
Thank you, Dr. Sabin. I will follow you by explaining about the child depression screening tool called Cdst, the screen that screen children at risk of depression aged from 7 to 14 years, and that will be used in the program to screen children at school, but also in health facilities. Honorable Minister, dear colleagues and friends, thank you for being with us. The depression is often found in chronic disease such as HIV and others, and in transgenerational trauma. And in my country, Rwanda, because of the existence of pediatric HIV, chronic disease, and the consequences of the 1994 genocide against the Tutsi 26 years ago, we have to pay special attention to the risk of depression in children. But the diagnostic and treatment of the depression in children is largely overlooked due to 2 reasons. No rapid, easy-to-use, scientifically accurate tool, affordable to do so, and the lack of trained personnel. So we had the need to create a reliable, easy-to-use depression screening tool adapted to Rwandan children, but also that will allow non-mental health specialists to contribute to screen the children at risk of depression, refer the potential cases to mental health specialists with a clear referral system from community to mental health clinicians, and also that is adapted to our culture. So we create the Cdst, and I did so with the fantastic support of great skilled and competent mental health specialists. You will hear their lead just after me, to ensure that the tool is validated, accurate, reliable, and that it could be used effectively to screen children at risk of depression. With doing so, increase the care and treatment those children receive. The specific objective of the Cdst are first to calibrate the Cdst so that we validate the cutoff of the Cdst, and the people who use it know when to refer because there is a risk of depression. And the second is to test the feasibility of using the Cdst in a routine pediatric mental health screening program in Rwanda, in health, and now in education. And the third is to facilitate the system of referral and counter-referral of children at risk to be depressed and depressed. Lastly, it was to facilitate the depression diagnostic and the follow-up of depression, and also to include and promote family therapy. Next slide. There are 5 steps in the development of the Cdst. First, we review all the depression assessment tool recommended by WHO. Second, based on this review, we create 11 items with mental health specialists to ensure the cultural accuracy. Since the Cdst was created in English, we translated in Kinyarwanda and back translated in English. And we pre-tested in 2 randomly sites, 1 urban, 1 rural, and the last step was the validation. The Cdst is composed by 11 items, and each is has 4 possible answers that are weighted from 0 to 3. And it can be administered in a very short time. It assesses the mood, the hope of living, the interest in leisure, how the child sleeps, the fatigue, the appetite, the concentration, the distraction, the anxiety, and the interpersonal relationship, the suicidal thought or attempt, and the feeling of guilt. The Cdst, as Honorable Minister said, is free for all over the world and easy to be adapted culturally with local specialists. So I advise the world to use it. Thank you very much. Eric, up to you.
Thank you very much, Prof. I'm going to take you through the methodology that we have used to validate this Cdst tool. And next, please. So we designed a study which was cross-sectional and which covered all the 4 provinces of Rwanda and the city of Kigali. We included children aged 7 to 14 years living with HIV who were on antiretroviral therapy and who knew their HIV status. By July 2019, we counted almost 5,000 children who were on antiretroviral therapy in the whole country. The sample size was estimated and the minimum required was estimated to be 283 children. And to get them, we sampled using 2 stages. At the first stage, we selected health facilities across the country and we used the random selection of 25 health facilities. And we need to say that each province had 5 facilities. On the second stage, we have selected eligible children, and at each health facility, we selected 12 eligible randomly, and this section was done at a facility. Next, please. So at her facility, after recruiting all the children who were eligible, we requested the assents form to the parents or to caregivers because they didn't have the age to consent by themselves. And after collecting all demographic information, socioeconomic and clinical data, we administrated the Cdst tool, and this was done by a trained psychologist who later also conducted the interview with the child. And this interview was to judge the child was depressed or not. And this, for the analysis, was considered as a gold standard. Next, please. All data were entered into an electronic form, which was an Android tablet, and exported to Stata software for analysis. And we performed this statistics and calculate the sensitivity and specificity, predictive and negative predictive values. And I need also to say that for every child, we have calculated the cutoff. We calculated the rates, and we used the receiver operating characteristic curve to analyze which could be the best cutoff for the Rwanda. And I pass my colleague Darius to talk about results. Thank you.
Thank you so much, Eric. Good afternoon, everyone. In the next slide, in terms of sample characteristic, our study team met with 296 children living with HIV and aged between 7 to 14 years old. The mean age was 12 years, and we had an equal proportion of male and female. As highlighted by Eric in the methodology section, we only recruited children who knew their status and who have already started antiretroviral therapy at the time of the study. And 30% of our sample have been on ART treatment for a period less than 5 years. 47% have been on treatment for a period comprised between 5 and 10 years. And 23% were on ART treatment for a period between 10 to 14 years, or basically since they were born. It is not an easy task for parents to disclose HIV status to children, and commonly parents delay disclosure. And for near to the half of the children we met, parents have been challenged to tell to children their status and requested the presence of a healthcare provider to support the process of telling children. The next slide, please. The graph on the left side presents the prevalence of depression found by experienced psychologists using clinical structured interview. 14% of children met diagnostic criteria of clinical depression, which means that 1 in 7 children we met living with HIV had depression. And the prevalence of depression found in this sample of children with HIV was much higher, 4 times actually. The prevalence found in the general pediatric and adolescent population study Honorable Minister cited the Rwanda Mental Health Survey done in 2018. In our sample, depression was significantly higher in adolescents aged between 10 to 14 than in children below 10, when they are starting the process of adolescent. Depression was higher in female participants and in children with non-suppressed HIV viral loads. On the right side of our slide, after mental health professional did clinical structured interview as a gold standard, we also administered the Cdst tool to participants, and Cdst scores were compared to results in diagnostic done by mental health professionals, and the table on the right shows sensitivity and specificity analysis. The cutoff of 6 provided a very good sensitivity and specificity compared to the rest of the scale, because with the cutoff of 6, the Cdst tool was able to correctly identify up to 90% of positive case of depression and identified as non-depressed 96% of negative case of depression by mental health professional, which is a good specificity and sensitivity. Next slide, please. And the following slides show a graph representing ROC analysis that confirmed that the best cutoff for our tool was 6. So with the overall probability that a child with depression is correctly identified is achieved with the cutoff of 6. In conclusion, our study team found that the Cdst tool could be a useful tool to screen and identify the 1 out of 7 children with HIV who have depression, and it can also be used to assess other children with chronic diseases. Our study was conducted in rural and urban health centers, and the Cdst tool can be used easily by non-professionals, mental health professionals, especially general nurses. And when children score 6 and above, they can be referred to mental health specialists for early treatment. As it was said in the introduction, there are not many free and open access rapid assessment tools for depression available. Then the Cdst tool opened the possibility for early diagnosis, improved access for treatment to depression, not only in Rwanda, but also in other limited resource settings. I thank you for your kind attention.
Thanks so much to the team for walking us through the way that the questionnaire was, the screening tool was evaluated and validated. It's fantastic to see that level of rigor going on. I'd like to now call on Dr. Nkenga Song to provide his remarks.
Thank you. Can you hear me?
Yes, we can.
Greetings from the Africa CDC, and what a pleasure to join you today at this very important event. I mean, first of all, let me thank the organizers for putting together this wonderful symposium or meeting to look at the Cdst tool. I've been listening from the start and really learning a lot. And particularly, let me start by congratulating Professor Agnes Vinoguajo for the extremely important innovative tool that we are sharing here today. I think from the conception, the development, the trial and validation, it really reflects the rigor that is required to bring forth this very important tool. I think congratulations from the Africa CDC for that important work. The second comment that I would like to share with you is my reflection on what this tool represents from our perspective. I think it represents 3 things. One is an African innovation that we at Africa CDC are very proud to know about and will be committed to championing across our 55 member states. The second thing is that the innovation, part of the innovation is the age group that this targets, the 7 to 14 years old school attendees, and the prospects of expanding this tool to other settings is extremely innovative. And the third thing in that I believe strongly in is that this is truly an example of investing in our future. I think this is clearly, if we miss these children and given the nature of the problem we're dealing with and the epidemiology of the problem that we're dealing with, if we miss this opportunity, then we fail to invest in our future. This is really a brilliant example of public health in action for our development. And I think I'd like again to really appreciate this effort and commit ourselves to expanding the rollout. My last comment is really where we stand. I think there's a saying that your stand in any issue is where you sit. I think I'm sitting at the African Union Commission. I think one of our role is to share experiences across our member states and promote them. And at the start of this conversation, somebody said, I think it was my friend Sabine mentioned that there was a need to promote our own tools. I totally agree with that. I think we are here to promote this kind of innovations, made in Africa tools that can serve other countries. There's no need inventing the wheel across our member states. So I will just conclude by saying that you can count on us. We are privileged we have been invited to be part of this. You can count on us as the Africa CDC to really work with you to expand these tools as we move into the implementation phase and the scale-up phase, of course, first of all in Rwanda, then across other African member states. So I really look forward to continuing the dialogue offline with my sister Agnes to explore ways that the African Union and Africa CDC can work with you to extend this to other settings. I thank you for the opportunity to contribute.
Thank you so much, Dr. Nkangasong, and it's so fitting to have you provide the closing remarks for the first part of this event, the launch, and just fabulous to hear the commitment and the support from the African CDC. We know how the African CDC works hard to improve access to health for the children of Africa, who are the future of Africa. So it's fantastic that you were able to contribute, and we're very grateful for your insight and wisdom. So that's the end of the first part of this amazing event, and we're now moving on to the second part of the event, which is a panel of international experts who will be providing their insights about COVID-19 and the impact globally on children and adolescents. So it's a huge pleasure for me. I've already introduced the people from the first part of the event, the launch, and some of those will be contributing to the second event. But we actually have some more speakers as well, and I'm absolutely delighted to be able to introduce to you and welcome Dr. Marwena Agbonito. She grew up in Maryland, USA, and went to Harvard College, where she majored in anthropology. She earned a Master of Science in Control of Infectious Disease from the London School of Hygiene and Tropical Medicine, and her medical degree was from the University of Maryland School of Medicine. Dr. Agbonito has interests in community psychiatry, street medicine, and global mental health. She is board certified in both psychiatry and child and adolescent psychiatry by the American Board of Psychiatry and Neurology. She currently works as a psychiatrist at a community clinic in Atlanta, Georgia, USA. Thanks so much for coming along today to speak with us, Dr. Agbonito. And I'm also delighted to be able to introduce to you and welcome someone from my patch of the world, Dr. John Juridini, who's a child psychiatrist and also trained in philosophy with a PhD from Flinders University, critical appraisal from the University of British Columbia, and psychotherapy from the Tavistock Clinic. Dr. Girodini heads the Adelaide University's Critical and Ethical Mental Health Research Group, which conducts research, teaching and advocacy in order to promote safer, more effective and more ethical research and practice in mental health. He also heads the Pediatric Mental Health Training Unit, which provides training and support to medical students, GPs, allied health professionals, teachers and counsellors in non-pathologizing approaches to primary care mental health, with a special focus on the social determinants of health. Thanks so much for coming along tonight, John. Tonight for you. I'd finally like to welcome Dr. Sue Hawkridge, who's clinical head of the Child and Adolescent Psychiatry Unit at Tygerberg Hospital in Cape Town. She's a senior lecturer in the Department of Psychiatry at Stellenbosch University and a clinical associate in the Department of Psychology at Rhodes University. Her current service commitments include leading the clinical team of the Tygerberg unit and outreach and support and children's institutions in the catchment area. Her areas of interest include early onset psychotic disorders, child and adolescent forensic psychiatry, pediatric psychopharmacology, and child and adolescent community mental health services. So thanks so much for these additional speakers who are going to contribute to the event today. And I'd like now to hand over to Professor Vinoguajo, who'll lead the webinar.
Thank you, Tim, for this great introduction of the panel. I'm delighted to continue to welcome you all to this event. As this second session will feature great global mental health expert and global health fighter who will discuss the impact of COVID-19 crisis on children and adolescent mental health. The discussion is extremely timely, given the deep disruption caused by the current pandemic in the life of children around the world, even in countries where the pandemic has not caused many deaths, because children are impacted by the stress of their parents, the stress of their communities, the stress of their nation. All over the world, the lives of children and adolescents have changed due to COVID-19 because of lockdown, stay home, school closure, economic shutdown, the usage of masks that change our physiognomies, death and suffering directly or indirectly through constant report from media, as well as evidence of increased domestic violence involving children as well. As a result of the COVID response efforts, such as many children and adolescents around the world are coping with significant anxiety, depression, and loneliness. You will hear about all this with concrete examples from global experts in mental health, specialists in pediatrics from South Africa, USA, and Australia, and also from WHO and CDC Africa. They will all share their experience, challenges, solutions, strategies, and we will take lesson on how to reduce the burden on mental health. So let's start by welcoming Dr. Bayingana Florence, the WHO Regional Advisor for Mental Health and Substance Use. She will share with us her experience and the view and recommendation of WHO. Florence, the floor is yours.
Thank you very much, Agnes. Once again, I'm very glad to be here with you all today and to make this brief presentation. So the next slide, please. The first slide shows mental health and COVID globally as well as in Rwanda. For the region of Africa, we have had a total of 1,201,101 by the last count. And this is about 3.6% of the global cases. So it's not too high, but we are feeling the impact here on the continent. The deaths have been 26,475 in the African region. This is about 2.6% of the global death rate. So that is still also encouraging in that it seems like it's encouraging, But when you are in the midst of having maybe a relative die or a friend die or something, health worker die, then definitely it's something that we feel. Rwanda has got 4,800 cases, 29 deaths, and 128 health workers infected. On the bottom there is the graph for Rwanda, which, as you see, looks much better than most countries. There was a peak in September, but it's been going down since. Next slide, please. The next slide shows poverty, culture, political, gender dynamics. So the mental health impacts of COVID. The mental health impacts are on adults. They are also on children. So you have overcrowded dwellings, you have lockdown, social isolation, economic impact on individuals and households. And for each of these, where there's an impact on the general population, there's an added impact on children. If we think about adolescents and how they like to socialize, many places they would want to be on the weekend hanging out with their friends, or in the evening or in the holidays. They can't do that anymore. That is a big challenge for them. Yeah, so when we think about intimate partner violence, we have had a lot about children being abused because of the spaces that they are confined in, maybe with frustrated or worried or anxious parents who find it very difficult to manage maybe the constant demands of young people saying, I want to go out, I want to do this, I want to do that. So that has been a problem. We also know that there have been a lot of teenage pregnancies, which are we're going to feel the repercussions of those as we go along. Can we have the next slide, please? The next slide, WHO did a survey, COVID and mental health. The global level results were presented on the 5th of October, and the report is now on the web, so everybody is encouraged to have a look at that. If you go to the next slide, you will see some of the specific results, the results that are specific to the Africa region. Out of the 47 countries in the WHO Africa region, we got a response from 28 of them. And of these 28, the status of services, mental, neurological, and substance use services was about 17% of them fully open. 17% fully open, which indicates that the other percentage means they were not fully, partially open or closed. The next slide, please. This slide is very, I think, important for the Africa region. This is specific to the Africa region. You can see which service, where the most disruptions are. The top chart there shows the second is school mental health. School mental health was very disrupted, completely disrupted is the first blue, and the darker blue is partial disruption. So if you add those two together, it's almost 90%, and that is a big one. As you go down, you will find services for child and adolescent mental health, services for children and adolescents. If you look in there, you will see them. Almost 80% if you combine disruptions, complete and partial. So there has been a big impact. On top of that, we have the impacts on the alcohol drug treatment programs. And we know that sometimes young people are the ones who are most in need of these services. Next slide, please. So this one shows the approaches to the disruption. The main difference here is that in Africa, we did not use so much telemedicine and teletherapy, which is the big bold line in the middle, which was used by the rest of the world. In Africa, our response was a little different. The next slide, please. These are some of the responses that are provided, resources for youth in response to the COVID developed by WHO. They are very specific ones. The next slide shows the links where you can get these resources and more on the next slide as well. It was very difficult to say so much in this limited time, but that's about as much as we could do. Thank you very much.
Thank you, Florence, for reminding us the harsh reality of the impact of COVID-19 on health in general and mental health in particular. It's a very rich presentation, and for the audience, we will make sure to put all this on our web. The next to speak is my friend John, the head of CDC. John, the floor is yours.
Thank you so much, Agnes, for again, and the organizers for giving me the opportunity to again contribute. Can you hear me?
Very well.
Okay, great. Thanks for the opportunity to share my thoughts again during this very important program. As a continent, we have gone through an extraordinary, challenging, and remarkable 10 months. And the impact is not just the numbers. My fear is that with time, we become insensitive to the severity of some of the numbers that we put out there, and they just become statistics. Like saying 1.5 or 6 million people have been infected in Africa, and 38,000 deaths as of today. It can actually become, but we have to always translate that into human lives and personal affections and emotions that are connected with this. These are our families, these are our loved ones, these are our brothers, sisters, and family members. So I think I always, during my weekly briefings, remind ourselves that this is something that will lead to have severe consequences and almost generational consequences, besides the number of the deaths that we are counting and the number of infections. So I think the mental health components of the response has been, in my view, and I want to be the first to admit, not received enough focus. We have been trying to put up a burning fire, and as we run and throw water in the burning fire, with certain aspects are, of course, missing attention. But that is also a reflection of the overall mental health situation of the continent that we are aware of. The first speaker, a colleague and sister from WHO, did presented some very startling statistics about mental health, how it's on the resource on the continent, and also probably underinvested in terms of public outcomes and analysis there. So I think that the COVID has provided an extraordinary opportunity, challenge, but opportunity, where we really can use the COVID-19 pandemic to analyze those vulnerabilities that are facing all of us. There are three things that COVID has taught us so far. One is how much connected we are. I mean, connected, generationally connected. That is affecting children, adolescents, adults, parents, and the elderly. Connected as a world and connected as public health experts and political leadership of the continent. I think I must say that it has been truly amazing. The second thing that COVID has exposed is the inequities that exist. Inequities in terms of access to healthcare delivery, access to services, and access to interventions there. And this also includes, of course, young adolescents and children in our community. And the third thing is that with the universality of the response. COVID has brought us as a continent closer. It has also exposed how divided we are as a people living and species living on the same planet. I think that is also all aspects that we should keep in mind and continue to invest in. So as Africa CDC, what are we doing? I think we've started to design studies, multi-country studies led by Dr. Mohamed Abdulaziz, who has tremendous experience in designing mental health studies. And the kind of tools that were presented in part one of this symposium will be extremely useful for us as we begin to focus and expand our understanding of the challenges of mental health as a consequence of COVID-19. My assumption is that it's going to even compound the undocumented or poorly studied mental health problems that we have as a continent. So the innovations that is coming out of Rwanda will be extremely valuable for us as a continent to begin to learn lessons there. And again, let me reiterate our Africa CDC's strong support to address this, what I call the missing link in our response. We have not, I repeat, we have not focused enough in understanding the impact of COVID-19 on the mental health care of our population, and which we should absolutely do. And to just conclude, as I indicated earlier, investment in our mental health is investment in the future, and investment in our young people is even greater investment to assure and guarantee our future and assure that our Agenda 2063 will be met. So again, I thank you for the opportunity to contribute to this very important symposium and discussion.
Thank you, John. We know that CDC Africa is doing a lot to improve access to mental health, but we heard your commitment to do more at Africa CDC about mental health of children, taking what is learned during this challenging period. A lot of food for thought that will enrich the coming discussion. Please now join me to welcome Marwena. Marwena, the psychiatrist working in USA, she will share with us the mental health challenges the children she cares of are suffering and how she helps them. The floor is yours, Marwena.
Hi, thank you everyone. I'm very excited to be on this panel to talk about this really important topic. And in the time allotted, I'll just give a brief snapshot as to the impact of COVID-19 on the mental health of the children and adolescents that I've seen in the community clinic where I work in Atlanta, Georgia in the US. Next slide. So the community clinic that I work in serves many uninsured patients as well as insured patients, and the vast majority of them are Black and or Hispanic. So these three issues of lack of universal health care, the impact of racism, and the economic downturn in the US are three stressors that I've really seen impact my patients and their families. Next slide. So I wanted to give a deeper dive into each of these issues very briefly. So first of all, regarding lack of universal health care. Unlike many other countries, the United States does not have a policy of universal health care. So instead, there's a network of safety net hospitals and clinics, such as the one where I work, that provide healthcare to people regardless of their insurance status. And as you can imagine, this differential access to healthcare resources causes a mistrust of the healthcare system, causes decreased access to healthcare, and worsens health disparities. One survey of 1,000 parents in the US reported that there was a significant decrease in employer-sponsored insurance in June 2020 compared to March 2020. And this is important because most adults in the US get their healthcare insurance through their employer, and that's also how they provide insurance to their children. So the drop was around 3%, which represents around 2.5 million children losing access to that insurance. Next slide. Next, when we look at the impact of racism, we know that communities of color have been facing higher infection rates and poorer clinical outcomes due to COVID-19 in the US. And this graph is from the CDC in the United States. And what it shows is the COVID death rate broken down by different race groups. And unfortunately, we see that there is overrepresentation of populations of color when it comes to COVID deaths. For example, Hispanic people make up around 19% of the population here in the US, but account for 40.5% of COVID deaths when adjusting for age. That's looking at the bottom part of the graph. Black people make up 13% of the US population and account for 28% of COVID deaths. And the American Indian and Alaska Native population is 0.7%, but they account for around 2.6% of COVID deaths. Next slide. So what is causing this difference in clinical outcomes due to COVID? And the factors are many. Some of them are listed on this slide, such as inequity in healthcare access, healthcare disparities, pre-existing chronic illnesses that predispose people to worsening outcomes when they're infected with COVID, higher unemployment. Black people are more likely to be essential workers or frontline workers, which causes them to be more exposed to COVID, and so on and so forth. Next slide. I think it's also important to mention that here in the US, as we've been dealing with the COVID pandemic, there's also been a great highlight on the impact of police brutality due to the murder of George Floyd in May 2020. Although police brutality has been highlighted in the past in the media, it has put another spotlight on this issue. And there's been well-documented research that there's a lot of vicarious trauma amongst Black people here in the US due to police brutality and hearing all the media about police brutality. So many people of color in the US and youth of color are dealing with anxiety from that source of racism, as well as the anxiety that we're all dealing with living through the COVID pandemic. Next slide. And then lastly, when we look at the impact of the economic downturn here in the US, due to COVID, there's been a lot of unemployment, or people aren't able to work from home or do not have work leave benefits and are working in places where they're more exposed to COVID. And so these factors increase risk of traumatic loss, either due to loss of life from COVID or economic fragility, which lowers quality of life. And we know that traumatic loss is a risk factor for PTSD, as well as other mental health issues. Next slide. In fact, one study done amongst families here in the US found that families who reported more than one COVID stressor, economic COVID stressor, being job loss, income loss, caregiving burden, or household illness, reported significantly more negative mood, worse sleep quality, and more uncooperative child behavior compared to those who reported 0 or 1 hardships. And those who reported all 4 hardships reported the worst parent and child mental health outcomes. Next slide. So this is just a brief snapshot as to 3 issues that I think are more particular to the context of COVID in the US and how it's been impacting the children and the families that I see in the community clinic. As you can imagine, many of the patients are dealing with all of these stressors at once, causing cumulative effects on them and worsening their mental health. Thank you.
Thank you, Marwena. That was a very informative presentation on your country, illustrating how COVID added to the complexity of pre-existing situation deriving from racial injustice, which increased due to impact of COVID on socioeconomic situation. Again, a lot we will have to discuss. Our next speaker is from Australia. We are now going to hear from Dr. John Juridini. John, welcome. The floor is yours.
Thank you very much. It's a privilege to be part of this international collaboration, and I speak to you from a very privileged environment where in my city there's been no new cases of COVID for many weeks, and a country which has had a very low rate of infection and a low death rate. But nevertheless, as earlier speakers have pointed out, we have been impacted by the presence and threat of COVID. And I want to pick up what the meaning of that might be for young people in particular. I mentioned about our privilege. We're also, I guess, privileged in the number of mental health services and mental health practitioners, psychiatrists and others that we have in Australia. And we do have a universal healthcare system. So you might be surprised to learn that people in Australia are no better off in terms of their mental health than they are in other places in the world, which raises some questions about whether having more mental health resources is actually what makes a difference for mental health. As Marwena's pointed out, it's the social determinants that really make a difference to people's well-being. And if you ask me what the interventions have been in Australia that have made most difference to mental health, I would say it's the government's complete about-face, a conservative government that's been all about individual success, recognising that we are a society and doubling the unemployment benefit and making available a JobKeeper allowance whereby businesses that had lost a lot of income were supported financially to keep people in employment. And these interventions, I'm sure, have had a very significant impact on mental health. But our mental health leaders in Australia who've been very powerful in attracting funding for mental health are rapid adapters. And, you know, one of the reactions that people have to a pandemic is to think, how can I sell some more of my product during this pandemic? And our mental health leaders have not been backward in that approach, talking about the need for more mental health resources at this time. I guess the question is, will that make a difference? Because we know that depression in young people is associated with poor outcomes. What we don't know is whether formal medical treatment of that depression actually improves those outcomes. So we hear people talking about the cost of untreated depression. We don't actually know that the cost of untreated depression is greater than the cost of treated depression in terms of productivity and suffering in our community. That might seem like a shocking thing to say, but if you go looking for the evidence, it's not there. So people have a kind of reflex of talking about the need for more treatments without really being able to produce the evidence that those things are helpful. It makes sense that they're helpful, but it's not necessarily shown that that's the case. The other thing that's been really interesting about the impact of COVID is the change in rhetoric from people who've taken the approach that depression is an illness like any other illness. It's a medical problem. We should treat it in that way. Those people tend to ignore the social determinants of health. But now all of a sudden they're saying there's an epidemic of depression, a silent epidemic that accompanies the epidemic of COVID, that they're effectively acknowledging that this is a response to people's environmental circumstances, to family violence and poverty and inequality. While we have a rich society in Australia, we have an unequal society, and inequality plays a really important part in young people's depression. I guess the final point I wanted to make is the importance of language. And the term depression, which in English is an ordinary language term that's been adapted for medical usage. And depression is a description. It provides no explanation for why a young person is distressed. And so it should come as a question to us, not as an answer. If we recognize that a young person is depressed, that's the starting point in understanding them, not the end of our process of trying to understand them. And we need to try together to come up with some kind of explanation. And earlier speakers have talked about, and I think from what I can gather, and I'm in no way an expert outside of my own culture, but it does feel that the Rwandan culture has a more natural understanding of the importance of family and society and the way that that shapes young people's mental health than our very individualistic society that wants to place the problem within the individual. And so the last point I wanted to make was about the existential threat of COVID to young people, and the idea that young people are unable to cope with the fears associated with COVID. But there's always been an unmanageable fear for young people. When I was a teenager, it was, nuclear winter. Really what our young people should be scared about is climate change. And what we should be thinking about is what as well as thinking about what the young person's distress tells us about how life is for them, it's what does that young person's distress tell us about what we're doing wrong as a society? How have we let these young people down who are depressed and miserable? The process in my country, unfortunately, is to medicate that distress rather than listen to it as legitimate protest about whether it's about local circumstances for that child living in domestic violence or poverty, or whether it's about the broader social environment in which they live. So I'd hate for they come to us from America, these American notions of individualistic approaches to mental health. I'd hate for that to be, I hate the fact that that's being exported to countries and cultures that have a much more sensible, community-based, family-based view of young people's suffering, rather than the individualistic culture that unfortunately is promoted in countries like mine. So I think I'll stop on that note. Thank you. Thank you very much for inviting me.
Thank you very much, John, for joining us and for sharing so many lessons on this, what you call epidemic of depression. This will be very useful all over the world. You tackle from the impact of socio-determinant of health, like Marwena did as well, and the structure of the society that increase or maintain distress of many origin, according societal choice, and asking fundamental question on the need of having evidence before taking decision in the health sector on medicating or not, and tackle the roots of the distress and not necessarily medicate. So very interesting. Now, I'm going to give the floor to Sue Hawkridge. You are our last speaker, Sue, but not the least. And you'll share with us how it is in South Africa, your experience and your challenges. You are welcome, Sue. The floor is yours.
Thank you. It's a privilege to be among you. Thank you for the invitation. I'm going to whip through this very quickly, but there are references available and the slides will be available as well. But this is a description of the effect of COVID on children from the inside out. We haven't had time yet to stand back and count things, but I've promised Prof. Agnes that when we do, we'll let her know. Can you change next slide, please? Thanks. I'll just talk briefly about the course of the pandemic in South Africa and our famous level 5 lockdown and what happened after that, the gradual easing while the curve was still going up, the mental health effects on children and adolescents and families, and where we find ourselves now, and then what we're going to do. And I'm going to talk very fast, otherwise I won't get through. So just briefly, there's the South African timeline. We're about to hit, in fact, I think we have just hit 700,000 infections, and you can see our S-shaped curve. It went up very steeply in a very scary time, but it's still going up. Next slide, please. This is what we're more scared of, which is the number of deaths, because cases are, as an infamous president has already pointed out, dependent on how much you test. And we haven't got wall-to-wall testing. So what we're looking at is deaths. And there you can see that there's a little kicker right at the end there, just when we thought we were getting out of the woods, we're heading back in. Next slide, please. This is our more reliable index, which is our excess deaths, which are picked up by the Medical Research Council of South Africa and available in their weekly reports. The number of deaths we think we have from COVID are under the red line, and the number of deaths in excess of our normal expected number are the blue line. And as you can see, they occasionally get intertwined, but we're still a bit short on our reporting. So the chances are that we're not, in some areas, not even getting between 30 and 60% of our COVID deaths notified. So it's been all around us and it's still with us. Next slide, please. So even before the first death in South Africa, just the day before, in fact, our government swung into action with an almost textbook preventive lockdown. And as somebody's pointed out, we've had one of the toughest lockdowns in the world, and we had that level of lockdown for about 5 or 6 weeks. And it was an almost total shutdown of the economy with a strict curfew. And I think what caused more irritation and unhappiness than anything else was no alcohol or tobacco. Enforcement was by the police, assisted by the army, and there were something over 300,000 arrests. There was no school, there was no daycare. Some parents were trying to work from home, some were trying to homeschool their children, and others were trying to find childcare for when they had to leave for their essential jobs. There was no exercise allowed in public spaces, and we had many wonderful memes online, people doing marathons in their very small backyards. There was possible substance withdrawal in the caregivers, which didn't help a lot, both smokers and drinkers. There were very high community anxiety levels. There was an absolute flood of information, mostly bad news, with general uncertainty, lots of contradictions. And for children and adolescents, there was potentially unsupervised access to media and the internet. And this is not just in middle-income households. We have very wide and deep penetration of smartphones in this country, and not everybody has supervision when they're accessing it. Next slide, please. So our experience with children who were already patients of ours and already diagnosed, the ones who had the most trouble with the lockdown regulations were people on the autism spectrum, children with intellectual disability, those with OCD, particularly with contamination fears, children who've already got disruptive behavior and who've probably gone off their medication for ADHD because of the general disruption of services, kids with depressive disorders, traumatized children from previous trauma, kids with eating disorders, and in fact, any disorder requiring regular medication like schizophrenia or bipolar disorder. And in particular, we ran into difficulties with parent-child relationship problems because putting everybody together in a pressure cooker has never been a great recipe for solving those. We provided emergency support as a clinic. We didn't close. And we had online telephonic support wherever we could manage to set that up. And we kept an inpatient unit running for acute admissions. Next slide, please. So our biggest problem was diversion of our resources to COVID-19 care, and that included staff members, nurses, and doctors. But mostly it was the things that you don't usually notice, like security guards. You should notice them more. People, of course, not things. Recurrent closure of district health facilities as staff became infected, an obligation to provide safe accommodation for both positive and PUI kids in the same space as we'd had before. There was a reduction in admissions for substance-related psychosis. That's in our country. It's most often methamphetamine and cannabis. There was an initial reduction in admissions for suicide attempts. And there were challenges for our frontline and other staff because many of them are medically vulnerable and a lot of us are quite old. And we also had to help provide other COVID duties and providing helplines and consultations for staff. So there was a general thinning out of our capacity. Next slide, please. The school system, for the higher income people, there was online schooling and parental supervision. And many parents tearing their hair out, but very proud of themselves for mastering Zoom. But most children had no access to this. And of course, in addition to that, they were missing their school meals. A large percentage of our school children rely on their daily school meal for any kind of adequate nutrition. Parents who were working in essential services struggled to keep their kids safe in dangerous neighborhoods, of which we have many. And there was widespread financial stress, despite the fact that our government did provide basic support for many people. But we've lost in excess of 2 million jobs. In our province, we've lost 300,000, and that's on the good end. So there's a sense of ongoing uncertainty as the authorities struggle to find a safe way to reopen a much needed economy in the face of a rising infection curve. Next slide, please. Adolescents in particular were hard hit by their isolation. We know how adolescents prefer or rely preferentially on networking with their peer group rather than grown-ups and even younger siblings. So they also suffered from the lack of a usual structure and the support provided by their schools, and mostly from a sense of a suspended future, because there's no idea when the school year was going to end, whether it was going to count, whether the end of year exams would be written, what happens to entrance to next year's university classes, are they going to be open for entrance, because are we going to have to repeat the university year? There was a lot of uncertainty. There was also anxiety about older family members, because our government communication, I think rightly, does repeat a lot how much more vulnerable older people are to COVID. And then for those, we lose 50% of our kids between grade 1 and grade 12 anyway. And for those who are on the brink, this was the ideal opportunity to fall off the track and stay off. So we've got a lot of children who are simply not going back to school. Next slide, please. The easing of the lockdown, you can see there it's been about 5 weeks to 6 weeks for every stage. The most disruptive thing has been, I think, the on-again, off-again reopening of schools. Now they're mostly reopened, but they're still platooning. So kids are going to school every second day or for every second week. The businesses have gradually reopened, pretty much everything now with the usual consequences, but our early childhood development centers haven't reopened yet in the main. So that's providing a lot of difficulty for people with young children. The health services have now got a great push to move towards normalization of services, but there is a huge backlog. Next slide, please. So our mental health sequelae, we've had a sudden, from level 3 onwards, a sudden surge in self-harming behavior by adolescents. And we've had an absolutely tragic increase in completed suicides and also serious suicide attempts in children under 13. Several of these related to a fear of infecting their grandparents or their foster parents who may have been elderly. We've had a return to what we call our normal levels of substance-induced psychosis, an increase in demand for admissions for aggressive behavior. And these are mostly kids on the spectrum or with intellectual disability, because parents simply cannot manage anymore with the child in the home all the time. And in fact, many of our special needs schools haven't reopened yet. And children and adolescents have begun to express real anger about their disrupted and derailed futures. Sometimes it's acting out, they'll go to parties, they'll catch COVID. As the second wave threatens, there's an increase in anxiety and hopelessness, and again, frustration. And we are still unable as a unit to provide support groups for many of our patients and also for their parents and grandparents. Next slide, please. So the current status is we're sitting with an absolutely huge budget hole with massive extra needs for things like PPE, and we're going to have cost cutting and we're going to have to negotiate that. And as you know, child mental health has never been at the front of the queue. Also, we rely on many community and school-based health services as well as NGOs, which are still not all fully functional. The sequelae of the pandemic will be long-lasting and will require expanded services. Our system's already overstretched. We've been working with other sectors to provide at least some sort of scaffolding for ongoing support for children, adolescents, families, and caregivers, so that we stand behind them to provide support and supervision if necessary. We're moving towards screening, which is going to be important, especially for mood disorders, task shifting and online or telephonic services where possible. And we're adapting to the current circumstances for the foreseeable future because we're not at the head of the queue for the vaccine either. Next slide, please. I need to tell you about Ario. Ario is a fat-bottomed dragon who has been wonderful in this children's book about COVID. So just in case you feel very depressed now, go read about ARIO. Thank you very much.
Thank you, Sue, for sharing with us the challenges faces, from the huge uncertainty of this challenging time to the risk faced by essential workers and the risk that no parents should neglect about the overuse of social media without supervision, knowing how bullying on social media is something that has been common. Now, dear panelists, I thank you for your insightful presentation with points that are thought-provoking and really with a global perspective. And I'm sure that the audience has gained a better understanding of the complexity of the mental health impact of COVID-19 on children and adolescents around the globe and the challenges that it implies. We will now go to the Q&A sessions. And I can see here some questions already sent. And the first is for you, Florence. According to WHO, depression is the third leading cause of illness and disability among adolescents. This year's goal of the World Mental Health Day campaign is increased investment in mental health. What role does WHO play in creating guidance with member states to ensure increased investment and in production of evidence-based intervention and guidelines as their response to the health need of children and adolescents in their countries? Long questions and challenge. You have 2 minutes to answer that. You are on mute, Florence. Florence, you are on mute.
Thank you. Thank you very much. Yes, it's an interesting, I think a very good question to ask, because we have talked about the burden of depression and other mental disorders among our children, but also generally, we have talked about the added problems that COVID has added onto the already strained systems. So then, if that is the case, what can WHO do about it? I can say that WHO has recognized the importance of strengthening health systems in general, but also strengthening mental health systems. That's why for almost every country of the region, there's a health system strengthening person. We have a technical officer. If they are not for one country, they may cover more than one country, put in those countries specifically to strengthen health systems. Within that health system strengthening, mental health and NCDs have been prioritized. So we encourage the governments, because WHO does not impose on governments. We have to encourage the governments to prioritize mental health. Once they have prioritized mental health, and if they feel they don't have the resources to respond or the technical expertise, then they would approach the country office. So for instance, in Rwanda, the government of Rwanda has actually approached WHO for support already in some areas. But if you want children's mental health to be one of those areas as well, then there would have to be that discussion with the country office. And the country offices, as I mentioned, have that person who provides the technical assistance, but we also have the support that can be provided from the regional office as well as from HQ, from Geneva. So yes, we are committed to strengthening mental health systems in the region.
Great answer, Florence. And also it shows us why and how mental health strengthening need to be tackled in an integrated manner with the overall strengthening of the health sector.
Yes. Yes, and driven by the country, just to add, driven by the country. WHO cannot drive that. Yes.
Advise and the countries with that. And also, you will see that CDC Africa will push and help our ministries of health to consider that. And John, the next question, I'm going to direct that to you. John, in most schools in Africa, they have been closed for the past 5 months, and some schools are still closed today. Some children are experiencing depression, anxiety, and isolation linked to the lack of contact with schools, friends, and communities. I have 2 questions for you. What challenges to African mental health system as Africa CDC observed with this global pandemic, and how are these challenges disproportionately affecting children? What is the way forward to support opportunities for tackling these challenges in the future?
So,
many questions, huh? Assistant is giving us a long questions.
Yeah, no, thank you. I think as I indicated earlier, I mean, with respect to the first question, what challenges to Africa's mental health system has Africa or CDC observed within this global pandemic, and how these challenges are disproportionately affecting children? 2 parts of the question there. I think there's obviously, as I indicated earlier, that the COVID-19 pandemic has further complexed our challenges of mental health issues. And clearly an area that was initially understudied, an area that was initially under-resourced, has been further compromised. That is clearly a fact. But as I said earlier, this is also an opportunity to reflect on new strategies to really engage and actually use COVID as the driver to strengthen our and raise awareness in the areas of mental health as a whole, and in children in particular. The children part is really unique because naturally we don't think about it. We don't think about children, mental health issues in children, which we should be doing. The way forward, I believe, will be that Africa CDC plays its convening role to raise awareness. I think one of the key strengths we bring to this dialogue is the ability to convene. I think we can, based on especially the data generated from Rwanda, use that as a catalyst to begin to convene consultations, continental-based consultations, starting regionally, to begin to bring to the surface the issues of surrounding mental health as a whole, but mental health for children in particular, because that is it interests me as a subset and a separate class of for consideration in public health. So I think, as I indicated, clearly the way forward is for us, Africa CDC, in the coming weeks, to again regroup with you all, but broaden the conversation from Rwanda to the entire continent, and we will be doing this with all of you. Thank you.
Thank you, John. And it's a very interesting way forward to take this challenging virus to drive us, all of us, to raise awareness on mental health need of children. It's a very good way to turn this catastrophe in something that can be a post-COVID area that is better for mental health. Dr. Darius, there is a question here for you. As a practicing clinician psychologist, do you happen to see children and adolescents with chronic disease, such as HIV, attending mental health setting in your practice to be treated for depression? And if yes, at which stage do they come for consultation, and how do they come and present themselves to you? With which reasons?
Thank you, Prof. Agnes. Yes, in Rwanda, we have mental health services at referral hospital, provincial hospital, and district hospital that receive children when they are referred for depression. I want to mention that we receive few of them, and I received some of them personally, but mainly at a late stage when they are exhibiting alarming behavior to parents and to health care providers. And we tend to receive more adolescents than children. And from my experience, I found that there are 5 most frequent reasons for consultation. They came mainly when they have attempted suicide, as highlighted by Dr. Bayingana, or we also receive them when they are no longer compliant to antiretroviral treatment. It's an issue among adolescents, or when parents found them that they have started to use psychoactive substance. It was also highlighted in the discussion. Or when there are intense conflicts around the origin of HIV, or when they are starting to form romantic relationship. So we receive them mainly when there are alarming behavior, and we think that the use of tools like the Cdst can lead to early diagnosis and treatment, even in young adolescents and in those who have depression without exhibiting external behaviors.
And there was like a postscriptum to this question. Did you see more consultation since the last 5 months? Meaning due to COVID, was there an increase?
Yeah, it's not easy to answer to that in terms of yes, but we have depression case linked to the lockdown period. For instance, when there are conflict at home and children don't have, they used to have the possibility to stay at school and enjoy with colleagues. And when they are at home, they constantly face that kind of conflict. And we frequently receive children having depression and suicide ideation, for instance, in relation to the lockdown period.
Thank you. And I think across all presenters, you talk about the high risk of suicide, what is quite uncomfortable to face when we don't want to understand that children have needs in mental health. As Dr. John from CDC Africa said, we have overlooked that and we need to do more. Eric, there is a question here for you. You link to the presentation and the rock curve that was used to show graphically the connection between sensitivity and specificity of the result for every cutoff of the depression. This has to be asked certainly by one of your colleague epidemiologists want to know by combining the sensitivity and specificity, it provides an area under the curve. So tell us what it means.
Yeah, thank you, Prof. Actually, the receiver operating characteristic curve it combines the sensitivity and specificity, and to produce the area which can be interpreted. So this requires to have a gold standards, which in our case was the psychologist's judgments. And you had also for every chart, he has the rates of depression according to the Cdst tool. So then we produce the sensitivity and specificity towards that judgments. So then by combining sensitivity and specificity, we got the area under the curve. So the methodology says that the bigger the area under the curve, the better is the cutoff. So as we have seen on the slide for Dr. Darius, the cutoff of 6 had the bigger area under the curve, and it was advised to be the best.
Yeah.
Thank you.
To help answering this question, we will post also on the web one article we published before using the ROC and with explanation for the one who have a question. Marwena,
thank you.
Marwena, could you please discuss further about some example you provide on how racism has worsened COVID impact in communities of color and impact on children?
Sure, yes. So there has been some data collected that show that Black people in the US are more likely to live in counties that have been higher affected by COVID, thereby putting them at more risk of COVID infection. There's kind of now 3 categories of workers now: those who are able to work from home, those who still have to be essential workers or frontline workers, or who are unemployed. And Black people are more represented in the latter 2 categories, unfortunately. So either more at risk of COVID infection or of economic difficulties due to unemployment. Also, Black people are more likely to have pre-existing conditions such as diabetes and asthma compared to the white population, therefore putting them more at risk of worsening COVID illness should they get infected. So in many different social determinants of health, unfortunately, we see that community colors are face the brunt of the negative brunt in terms of those disparities in the US.
So in one hand, more of certain disease, and the other hand, more socioeconomic distress. John, from Australia, from your experience here, I read the question, as a researcher and an advocate for ethical research, how can we as a research community ensure that the impact of COVID-19 on children and adolescents' mental health are ethically and sufficiently studied in order to draw transferable lessons that will be important to prepare for the next pandemic?
I think the important thing is to allow ourselves to be critical about the research that we do and is available to us, to not come into it with preconceptions, and to be alert to harms. I mean, one of the really worrying things about vaccine development is that people in their rush to get a life-saving vaccine are prepared to put aside the usual rigor with which we look for harms from any new treatment. And I think that's, you understand where people are coming from in that, but I think we need to balance that by being really assertive in looking at the harm of anything that we do, being prepared to acknowledge that a favoured intervention might carry harms with it. Of course, that's not necessarily, I mean, you might still go ahead with the intervention because you might judge that the benefits outweigh the harms. But if we turn a blind eye to harms, that's when we get ourselves into bad predicaments, as we have with a number of medications and other interventions over the years, because we've been too eager to respond to the hope that the research will solve our problem for us. So it's mainly about a kind of healthy skepticism, I guess, about what research can offer us.
And what do you advise, especially during this, with this new virus? We have seen so many proposals for treatment that within a month were withdrawn, etc. What do you, a bullying of publication of fake news in the science area? How do you advise us? What can we do to be cautious?
I think it's just really important to look critically at whatever's offered to us, and you know, sometimes we're not we're not given access to the data we need in order to make a critical judgment about whether an intervention is going to be beneficial or not. And, you know, one thing I'd hoped from the epidemic would be that it would lead to much more data sharing, that people would put aside competition to come up with the profitable vaccine and would, you know, I think if science were working at its best at the moment, every lab that was working on a vaccine would be putting out a blog every day, updating the whole world about what's been happening in their laboratory. But sadly, that's not what we're seeing.
Absolutely. So, Sue, the current pandemic threatens to roll back the progress we have made in the health sector, as well as in other areas of human development. What mechanism or alternative has the South African healthcare system put in place to ensure the continuation of mental health care for its patients?
That's a good question. I think it's early days yet. Our president, as I speak, is just unveiling the economic rescue plan in Parliament this afternoon. So we'll see where the health system fits into that. But we have mechanisms for making sure that people don't forget about mental health services. And it's really up to us. It's up to the healthcare workers and the people who use mental health care services to keep on pushing. It's, I think, going to be one of those situations where we all jostle around our scarce resources and just have to keep fighting until we come to a fair, equitable resolution about sharing what's available. We keep trying to persuade, and I think people do pay it lip service, politicians, how much of an investment it is to invest in child and adolescent mental health services, and how if they ignore it today, we're going to be reaping the consequences of poor services for children and adolescents for generations to come. The evidence is out there, but it's a message which easily gets lost when our biggest problem at the moment is how to feed people, is how to make sure that people don't actually starve to death. So it's quite hard to make sure that people keep mental health in mind. And that's more a matter of public advocacy. So that's where we are at the moment, publicly advocating.
And all of us. So we are reaching the end of this very rich conversation. I thank you all the speakers for your the great information and insight you have shared with, I thank with the audience. I thank everyone to have participate. And I thank the host institute, which is the Health Equity Research Institute of UGHE. We had brilliant questions as part of this event, and I would like to extend a warm thanks to all attendees for your strong engagement. I have a list of questions, non-answer, but I commit to answer all questions sent up to now through another platform called Ask Professor Agnes. It will be on Twitter. The speakers will help me to answer those questions, and I will tag them to know who have answered to that. And also, if you want to know more about our Institute of Equity Research, please go to our website. All is there. Very interesting collaboration to have. And thank you all. I wish you a good morning, good afternoon, good night, according the place you are. And I will give you an appointment in 1 month from now for a next webinar from UGHE. So bye, thank you, speakers, thank you, the attendants. Florence, my two Johns, Tim for hosting us, Marwena, Sabin, Honorable Minister, all of you, Darius and Eric, all of you, thank you. And also the team who have made it happen, the communication team, the IT team, and the team in my office. Thank you all. A lot of thought for the children mental